Welcome everybody. Thank you for joining, and today we are going to discuss heart failure management. In the previous classes we have discussed the etiology, the pathophysiology of heart failure, what are the clinical presentations of heart failure patients, and how are we going to work up these patients. Today we will discuss solely the management of these patients. In particularly, we will discuss patients who have heart failure with reduced ejection fraction. So let's start our lecture. So just to have a quick recap of what we have learned so far, we know that heart failure is a complex syndrome that develops when the heart either fails to pump blood at a rate commensurate with the requirements of the metabolizing tissues or is able to do so only with an elevated diastolic filling pressures. And as far as the epidemiology of heart failure is concerned, heart failure patients are generally older patients and they have multiple comorbid conditions. For example, hypertension, diabetes, coronary artery disease, storage diseases, systemic disorders, etc. So a long list of etiological factors that we discussed previously, and it affects about 64.34 million people worldwide. So this is a large number, right? Before moving into the details of heart failure management, let's have a quick recap of what are the components of heart failure management. We know that heart failure management requires patient education, pharmacological treatment, certain advanced therapies, and the non-pharmacological treatment options for these patients are, we will going to discuss them in the coming slides. They should receive evidence-based medications for improvement of their heart failure symptoms and, if possible, survival, and also they should be considered for advanced therapies in selected cases. Patients ultimately sometimes may require heart transplantation. The non-pharmacological treatment options for these patients include regular aerobic exercise, and regular aerobic exercise improves functional capacity and symptoms. Sodium-restricted and fluid-restricted diet should be encouraged in these patients, and during acute exacerbation, activity limitations are reasonable. For patients with troublesome hyponatremia, sodium restrictions to 2 to 3 grams per day and fluid restrictions of up to 2 liters per day should be considered. In suspected early heart failure, the guidelines from the American College of Cardiology Foundation, the American Heart Association, Heart Failure Society of America, and European Society of Cardiology recommend the following preventive measures to reduce patient risk factors. And early heart failure, by definition and by the criteria specified in the current guidelines, are stage A and stage B patients. Patients who do not have either structural heart disease or have structural heart disease without symptoms in the presence of risk factors for heart failure. So these patients should have cardiac risk factor modifications, including thorough management of their blood pressure, improving their sedentary lifestyle, treating any underlying condition that could precipitate or lead to heart failure in future, smoking cessation, diabetes control, weight reduction, and engaging in regular physical activity. Every patient with stage A and stage B heart failure, even with stage C heart failure, because pharmacological therapies are generally recommended for patients with stage C heart failure, and in stage A and B, because the symptoms haven't developed yet, but these patients require thorough assessment, risk factor modification, and all the preventive measures that are outlined in this slide and mentioned in details in the guidelines should be followed, right? And when we talk about the pharmacological therapy for heart failure, the goals of the pharmacological therapy are to reduce the preload and afterload in these patients, and also to inhibit the neurohormonal activation and improving left ventricular ejection fraction. but in most cases improving the left ventricular ejection fraction or the reverse remodeling may not be possible. So any patient with heart failure, your goal is straightforward: relieve their symptoms, improve their mortality and morbidity, because these patients frequently have exacerbations and they are landing in the ER and into the uh, hospitals now and then, again and again, and that perpetuous cycle generally results in increased morbidity, medication intolerance, non-compliance, and increased mortality, right? The medication classes which reduces the preload and afterload, basically these drugs act at different levels, and basically they act as vasodilators or reducing the preload, that is contracting the intravascular volume. They are diuretics, vasodilators, angiotensin converting enzyme inhibitors, and ARBs, or in some rare cases a combination of AC inhibitors ARB therapy. So vasodilators are basically nitrates that we are prescribing to these patients, although they don't have any mortality benefit in these patients, but because they improve the hemodynamics in these patients, so the symptoms are uh, less frequently encountered in these patients. The inhibitors of neurohormonal activation are AC inhibitors, ARBs, beta blockers, and aldosterone antagonists, right? So these classes of medication are given to these patients uh, to improve their morbidity, mortality, and if in certain cases they even can result in improvement of the left ventricular ejection fraction as well. The new kid in the block, and this is the most attractive and the most well established recent addition to the heart failure medications, and these are the angiotensin receptor neprilysin inhibitors, Entresto or Sacubitril valsartan. The heart failure with reduced ejection fraction patients in whom there is no history of angioedema, and in those patients ARNI therapy significantly reduce death or hospitalization, particularly if they have moderate to severe heart failure and left ventricular systolic dysfunction. But the recent updates and the recent studies have pushed their case even for heart failure with preserved ejection fraction, and now they are also recommended for patients with heart failure with preserved ejection fraction. They work by inhibiting the renin-angiotensin-aldosterone and neutral endopeptidase system, and the recently added drug is empagliflozin. This is an SGLT2 inhibitor. Originally, the drug was developed as an anti-diabetic medication, but the studies conducted over the past years have shown their benefit in heart failure. And recently, very recently, I think in the previous uh, month, February, the FDA has approved empagliflozin for heart failure regardless of ejection fraction. So they can be prescribed to any patient with heart failure, whether they have reduced ejection fraction, whether they have preserved ejection fraction or mid-range ejection fraction, or if those patients uh, are at risk for having mm, uh, developing a heart failure regardless of their diabetes state. This diagram has been adopted from the guidelines of heart failure, right? So let's have a look at it, and we see here that this basically is the treatment strategy for patients with heart failure with reduced ejection fraction and who are stage C, means that they have symptoms, right? So all these patients should be on ARNIs, AC inhibitors, ARBs, or evidence plus evidence-based beta blockers with diuretic agents. All these patients should be on 3 medications. Stage C, heart failure patients should be on 3 medications. And what are they? They should be on ARNIs, AC inhibitors, ARBs, depending upon the patient profile, plus evidence-based beta blockers, metoprolol, succinate, bisoprolol or carvedilol, and diuretic agent as required for symptomatic treatment. Next line of therapies requires a certain type of parameters. For example, if you are trying to add aldosterone antagonists to these patients should have preserved renal function with the eGFR of greater than 30 mL per minute per 1.73 meter square body surface area, or their creatinine should be less than 2.5 milligrams per deciliter in male and less than 2 milligrams per deciliter in females, or their potassium should be equal to or less than 5 milliequivalents per liter, plus they are really symptomatic NYHA class 2 or 4 symptoms. And the same profile patients who meet the eGFR criteria and they are having NYHA class 2 or 4 symptoms, SGLT2 inhibitors can be added to these patients as well. Diuretics are usually added in addition to these medications in order to relieve the volume overload status in patients with NYHA class 2 or 4 symptoms. The dose can be up or down titrated depending upon the volume status and the electrolytes. For persistently symptomatic black patients, despite ARNI, beta blockers, and aldosterone antagonists, SGLT2 inhibitors, and NYHA class 3-4 symptoms, hydrolysine plus isosorbate dinitrate can be added to them. And for patients with resting heart rate of greater than 70 beats per minute on maximally tolerated beta blockers doses, and those patients should be in sinus rhythm with NYHA class 2 or 3 symptoms, ivabradine is another option. We know that every heart failure patient is prescribed these medications: evidence-based beta blockers, AC inhibitors, ARBs, and ARNI therapies. They should be on these medications in addition to diuretics, right? And this is the starting strategy for most of the patient. And we talked in the previous slide that the additional medications, the SGLT2 inhibitors, the aldosterone antagonists, even for black patients, hydrolysine and isosorbate dinitrates, ivabradine, can be added incrementally to these patients depending upon additional parameters, right? When we talk about ARNI therapies, if patient is previously on AC inhibitors and we are switching this patient back to ARNIs, we should ensure a 36-hour off before initiation. The washout period is mandatory. With regard to dosage of ARNI therapies, if the patient is taking equivalent of less than 10 mg daily of enalapril or equivalent of less than 160 mg per deciliter of valsartan, these patients should be started on Entresto 50 mg BD twice daily. On the other hand, if the patient is on higher doses of enalapril or valsartan, means that these patients are taking more than 10 mg of enalapril or more than 160 mg of valsartan, 100 mg twice daily Entresto can be prescribed to these patients. And in 2 weeks, reassessment is required for tolerability. If possible, increase the dose stepwise to target of 200 mg twice daily. During treatment, monitor the blood pressure, electrolytes, and renal functions after initiation and during titration. AC inhibitors and ARBs, which were the first-line medications in the previous heart failure guidelines, are now considered in patients where ARNI administration is not possible. Consider increasing doses of AC inhibitors and ARBs every 2 weeks until maximum tolerated or target doses is achieved. Monitor blood pressure, renal function, and potassium after initiation and during titration. Evidence-based beta blockers are carvedilol, metoprolol, succinate, or bisoprolol. They are initiated and consider increasing doses of beta blockers every 2 weeks until maximum tolerated or target doses is achieved. Monitor for heart rate, blood pressure, and for signs of congestion after initiation and during titration. Coming to advanced treatment options for patients with heart failure. Advanced treatment options for patients with heart failure can either be inotropic support, it can either be mechanical circulatory support. I'm not going into the details of inotropic support for these patients because it is controversial. The guidelines give it a 2A or 2B recommendation in most cases, and it is associated with increased mortality. So I will straight away move on to mechanical circulatory support for these patients. In general, for patients in acute cardiogenic shock due to heart failure, the International Society of Heart and Lung Transplantation guidelines support mechanical circulatory support devices as a bridge to transplantation therapy or a destination therapy for patients at high risk for 1-year mortality. Addition considerations by the International Society for Heart and Lung Transplantation recommendations include reserving long-term mechanical circulatory support devices for patients in acute cardiogenic shock in whom there is unrecoverable ventricular function or ventricular function that is not likely to recover without long-term mechanical circulatory support. Inability to maintain normal hemodynamics and vital organ functions with temporary mechanical circulatory support devices, or inability to be weaned from temporary mechanical circulatory support devices or inotropic support. Capacity for meaningful recovery of in-organ function and quality of life, and reversible end-organ damage. Irreversible end-organ damage is generally considered a contraindication to mechanical circulatory support. Also, as for the aforementioned, the International Society of Heart Lung Transplantation does not recommend long-term mechanical circulatory support devices for patients in acute cardiogenic shock who have irreversible end-organ damage, who are not inotrope dependent but whose history is positive for heart failure, or who are able to maintain normal hemodynamics and vital organ function. Can we discuss this, that mechanical circulatory support devices are not recommended in acute cardiogenic shock who have irreversible in-organ damage and who are not inotropic dependent but whose history is positive for heart failure or who are able to maintain normal hemodynamics and vital organ functions. Cardiac transplantation, and what is the criteria? Any patient with refractive cardiogenic shock, there is dependence on intravenous inotropic support for adequacy of organ perfusion, peak oxygen consumption per unit time, that is VO2 below 10 ml per kg per minute, severe ischemic symptoms with consistent limitations of routine activity that are not amenable to revascularization procedures, CABG or PCI, recurrent symptomatic ventricular arrhythmias despite all therapeutic interventions. These are the major criteria listed here for patients eligible for cardiac transplantation. Contraindications to cardiac transplantation include active infection, severe peripheral arterial or cerebrovascular disease, irreversible pulmonary hypertension, active malignancy, significant renal failure with creatinine clearance less than 30 ml per minute, systemic disease with multi-organ involvement, other serious comorbidity with a poor prognosis, body mass index over 35 kilograms per meter square, current alcohol or drug use, and insufficient social support to achieve compliant care. Thank you so much. I hope you have learned something from this lecture. If you like to learn more about heart failure, I will recommend you to subscribe to the channel. Thank you.